Recording in progress.
Okay, we just asked that everybody would mute if you're not speaking. That would be great. Welcome you to put in the Zoom both your name and your agency. This is another way of networking in these days, to be able to see who all is attending and get to know some names and agencies. And so welcome to today's T&E series. My name is Deb Jones. I serve as the director for the Office for the Homelessness Coalition, oversees and spearheads the county homelessness coalition as a whole. I'm letting people in the room as we speak here. And so really delighted that all of you created and carved out some time for today's session. We are so excited to be able to focus on mental health and mental health, the 302 commitments, and very delighted that we have three agencies represented here, three experts into the field, if I might say, with Rebecca Sangri coming from BHDS's Crisis Intervention, Ketra Fori with Penn Medicine's hospital-based services, and then Leah Holmes as a mission director for Lancaster Behavioral Health Hospital. And so many of you have been anticipating this session so that we can learn more about 302 commitments and the criteria that's needed, and then the system that's in place here in Lancaster. So we will be monitoring the chat, but we're asking that all questions be at the end. We really want to get through today's content. It's really valuable. It's great. And so we will have a time for Q&A at the end. And then there's the last slide that has a QR code for an evaluation, because we want to hear from you today, both about today's session and then about future sessions that you have an interest in. So with that, Beth is in the background from our office and going to be advancing the slides. So we get to start off with you, Rebecca. If you take it from there, that'd be great.
Hi, good morning. So as Deb said, I'm Rebecca Sangri. I'm the Director of Crisis Intervention here in Lancaster County. So I'm just going to kind of go through what happens before they get to the hospital in regards to the 302 process, and then pass it on to Ketra and Leah to talk about kind of what happens after that. So if you want to go to the next slide, Beth, that would be great. So for those who aren't familiar, Crisis Intervention Services is licensed by the state to provide phone, mobile, and walk-in crisis services. We operate 24/7, 365 days a year. We're staffed in the office 24/7, so we don't do any remote work. We always have someone here in our call center. We answer the county crisis line, which I'm sure most of you are familiar with. It's 717-394-2631. And then we also are a 988 call center. So we answer the calls for 717 and 223. And if there are local exchanges in Lancaster or Lebanon counties. Our primary service is to complete mental health assessments and provide crisis intervention counseling. The bulk of what we do is over the phone. A lot of the folks that call in just need to talk to someone, work through a crisis, a stressor that's going on with their life, and don't necessarily require anything beyond having that crisis intervention counseling. However, we do oversee the 302 commitment process in Lancaster County. So anytime there is a 302 being considered, typically that will come through us, except for a few very specific cases. So if you want to go to the next slide. So the Mental Health Procedures Act is the law that governs all commitments in Pennsylvania. You can look at it and read it if you want. It is very dry and it is very boring, but it does guide how we process commitments and the criteria that need to be considered when a commitment is being determined whether it's going to be upheld or not. So You can certainly take a look at that. It goes through the whole process from kind of start to finish. In Pennsylvania, each county interprets the Mental Health Procedures Act differently. So if you've worked in another county or you've had experience with how another county does 302 process or anything really related to the Mental Health Procedures Act, it doesn't necessarily mean that that's how it's done in Lancaster or any other county in Pennsylvania. So it's really important that wherever you're working with someone, you're talking to their crisis services to really make sure that you're going through the process that that county has in place. So just something to keep in mind if you do have experience in another county or have an individual you're working with who is in another county when they call you in crisis, it really is best to talk to the crisis service in the county that the individual is located in. You can go to the next slide. So 201 versus 302, kind of what's the difference? Because those are going to be the two terms that you'll hear the most. If you want to hit the next slide. So a 201 is what we refer to as a voluntary commitment. That's when the individual has elected to go to the emergency department for an evaluation. It's their own decision. They're going of their own free will. It is always the preferred method. It is much less traumatic. It does not require police transport. They can go on their own. They can get a ride there. They can go via EMS. So it isn't quite as traumatic as when a 302 has to be implemented. We as the county, as the crisis, we have to explore whether or not the individual is willing to go on a 201 prior to completing a 302. So if somebody calls into our office and says, I want to 302 someone, we are going to ask, have we talked to the individual about going voluntarily? Can we speak to them? Unless there's imminent risk, meaning that individual has said they are going to go harm themselves, they have left the scene, there's nowhere to reach them, and we need to move very quickly. We do try and reach the individual and explore whether they're willing to go voluntarily. Crisis does not need to be involved in the 201 process. So if an individual is choosing to go to the hospital on their own, we do not need to be called. You certainly can call us and let us know that you're working with someone who, is having some struggles, feels like they need an assessment, and we will certainly add that to our board where we track all of our cases and follow up with whatever ED they go to. But if they want to go, that's their right, and we do not need to be involved in that process. In fact, we don't know about most of the 201s in Lancaster County. So that's kind of the 201 process in a brief overview. If you want to hit the next. So the involuntary commitment, which is the 302, would not be completed if the individual is willing to go voluntarily. We don't do 302s just in case. So if someone has said they're willing to go voluntarily, we don't kind of hold a 302 in our back pocket in case they decide they want to leave the hospital. Typically in those instances, the hospital, and I'm sure Ketra can talk about that more, would initiate a 302 if they felt like they needed to be maintained in the hospital until a full evaluation could be done and an assessment and determination can be completed. So I know we get that question sometimes, like, well, can we just do it just in case somebody gets to the hospital and decides they want to leave? We would not do that. We will ask to speak to the individual that is being petitioned, or we'll attempt to outreach if possible. So if you're on scene with someone, we will probably offer to come out and meet with you and meet with the individual and do an outreach to try and determine Is this really meeting 302 criteria? Are there other supports that could be developed, and kind of help you with that process? The important thing with the involuntary commitment is any behaviors used in the petition, which I'll talk about a little bit then, have to be from within the last 30 days. So the key to a 302 is that there's imminent risk. So if all of the behaviors are from 29 days ago, that can play a factor in whether or not it would be upheld by the delegate or upheld in the ED. So they're looking for, and what the crisis worker will talk to you about when you're petitioning a 302 is what's going on now? What are the behaviors that are putting that individual at risk now, or within a very tight time frame of when you're calling to do the petition? Certainly information that has been within the last 30 days can support a petition, but what they're really looking for is what is the imminent risk at that time. So that's kind of the 302, and I'll go into more detail about that. So if you want to hit the next slide. So this is kind of just fast facts. This is kind of how we explain a 302 to people. So a 302 is used when a consumer is engaging in dangerous behaviors related to their current mental status. That's really important. It has to be related to their mental status. It has to be related to their mental health. That's what's in the law. There has to be clear and present danger. Typically, most of our petitions are based on suicidal ideation, can be based on homicidal ideation, inability to care, and self-mutilation, severe self-mutilation. So not superficial cutting, but someone has cut so significantly that they need medical attention, that it's significant medical attention is needed. Behaviors must be related to a mental health diagnosis. The law and the act clearly states that it cannot be based solely on substance use, or a cognitive disorder or dementia. So those are kind of exclusionary criteria. Obviously, we have lots of people we work with who are dually diagnosed. They may have a substance use disorder and a mental health diagnosis. The behaviors have to be related to the mental health diagnosis, and that is kind of what we're looking for in the petition statement. That would be what I think I can say that would be what the emergency department of physicians are looking for when they're meeting with the individual and reviewing the petition. So involuntary treatment on a 302 cannot exceed 120 hours. I know there's kind of this thought out there that if a 302 is done, it keeps them in the hospital for 72 hours. We hear that all the time. 72 hours has nothing to do with a 302. So it's 120 hours from the time that the 302, is upheld and they've arrived in the hospital. So essentially 5 days. And then there's a whole process after the 302 if they are admitted to a facility that is also outlined in the act, and how an individual continues to be on a commitment in the inpatient setting. A mental health delegate approves or denies the warrant. So when a petition is done, it is reviewed with a mental health delegate, which is appointed by the county administrator. So our BHDS's executive director appoints those individuals, and they make a determination as to whether or not the petition will be upheld or denied. The police must serve the warrant. So crisis doesn't serve the warrants. EMS don't serve the warrants. Sometimes they will transport if there's a medical issue or they need medical attention. But the police will be on scene and kind of make that determination. So what that means is, in most instances, when the warrant is served, the individual is handcuffed and they're put in the back of a cruiser and they're taken to the emergency department for assessment. So it is pretty traumatic for individuals. This is how the law is set up. This is how Pennsylvania does this. So not really something we have a lot of leeway on. So a person on a 302 may be given the opportunity to sign a 201, and that's decided by the examining ED physician. Again, Ketra can probably talk more about that, but typically, you know, they do afford the individual the opportunity to sign a 201 instead of being admitted on a 302. So if you want to go to the next slide. So what happens if you are, you know, working with an individual and you're thinking they need to be in the hospital, there's some behaviors or concerns regarding their suicidality or something of that nature. So the first step you would take is to call crisis. 302s are all processed through our office. So first step, call us and we'll gather information and triage for potential risk and kind of talk through what you're seeing and what's going on, what they've said. And does it seem like it really meets the threshold for a 302, or is there something else that could be implemented? We attempt to do an outreach with every 302. Sometimes that's not possible due to staffing, but we are almost fully staffed at this point, which is quite significant for us. So if you know, if you are calling in and we know where the individual is, we will probably ask to come out and do an assessment in person with that individual and have you there as well. We will do it over the phone in instances. Staff have to get supervisor permission to do that. If possible, we'll assess the individual, assist any potential petitioner with writing the statement. And then there's a waiver form that is reviewed and signed by the petitioner. So the waiver form is something that lays out for the petitioner what their responsibilities are as the petitioner. It essentially, the biggest one is that you may potentially have to testify at a 303 hearing, which is that next level of hearing if that's necessary. And then the other big one is that if it is found that you have lied in the petition, it is prosecutable. So we go over, it's a whole list of responsibilities. And the individual who's petitioning would sign off on that. So if you're calling in, we would, and wanting to petition a 302, we would consider you the petitioner of the 302. So if you hear that term, that's kind of what that means. And then we would walk and help you write the petition statement. So once we do that waiver, you say, yes, I understand my responsibilities. I'm good with that. I'm in agreement. Then we would have you write a statement that indicates all of the concerns that you're having, the statements the individual has said, and then we would sign off on that, and that would be your petition statement. Once you have done the petition statement, that is when the crisis worker will contact the mental health delegate. So it is not the crisis worker that decides whether or not your petition is upheld or denied. That's the delegate's decision. So they simply call, and all they can do and all the delegate can consider is what's in that petition statement. So that is why it's important that the pertinent information is included, because they're not taking any other information into consideration. They're hearing the statement and they're making a decision based off the statement. If it is approved, then that's when it becomes a civil warrant. The mental health warrant is issued and we contact the police jurisdiction which the individual is located in to serve the warrant, and then they will transport to the ER. If the petition is not approved, then we would work with the individual, if they're willing to work with us, in what other supports can we put in place? Can we do some follow-ups with you? Do you have a case manager? We'll make sure the case manager reaches out to you, the next business day. Do you need some referrals to something? Can we refer you to partial? Can we do you know, try and help connect you with case management if you don't have it. So, so those are all kinds of things that we look at. Unfortunately, a lot of people who are being 302'd are not necessarily receptive to, a whole lot of supports that we may offer, but you never know. So we certainly want to try and offer that if they are. I'm not sure if that's my last slide or not. So if you want to go to the next slide. Oh, so if you have any questions, call us. If you're not sure if a petition is appropriate, call us. If you want us to, you know, talk through whether or not you should be petitioning, or there's something you're seeing that is concerning, you know, feel free to call us. We document everything. So, you know, if you call us one day and it's not, we talk through it and it doesn't seem like it's quite meeting criteria, but 3 days later, something else happens and you call back in, you know, they're going to be able to see what that previous conversation was and kind of what the recent contacts have been. So please, you know, call us. Please use the 394-2631 number. We know if you call that number, it is coming to our office. 988 is not geolocation or geo routing. It's simply based on area code. And so if you happen, as a lot of people do, have an area code that is not 717 or 223 and does not have a local Lancaster exchange, you're going to end up with a different call center. You won't end up with Lancaster. So we really stress with, you know, professionals and providers who are working in the field, who are working with individuals, the best way to guarantee that you are going to get Lancaster's crisis is to call our main number, you know, our call center directly. And then there isn't any confusion when you get someone and you start talking through a case, and then ultimately you find out you're with the call center that does not cover Lancaster County. So I think that's my part, and it's on to Ketra.
Thank you, Rebecca. So my name is Ketra Forey, and I am the manager of our hospital-based behavioral health services at Lancaster General. So then I'm going to be talking about when we have a patient who presents to the emergency department for a mental health evaluation, what happens and what does that look like? Next slide. So whenever a patient presents to the emergency department with what we consider a behavioral health chief complaint, that could be an individual who has substance use concerns, an individual with mental health concerns, maybe it's psychosis, kind of anything. And they either walk in or they drive in on their own. The first thing that happens is that the patient is screened by security. So for any of you that have been here to the emergency department recently, in our main door, there is a new metal detector and security that is there. So every individual who walks into the emergency department does get screened by security, and any belongings are put through an X-ray machine just to ensure that no one is bringing in, you know, any type of weapons, animals, things of that nature. Because we get, you know, last week we had a turtle and some lizards that found its way in. So there's always something. After that, the individual would walk directly up to registration, and they would be registered and then put into a waiting room. The patient then is taken into triage by a nurse, and then the nurse and or a medical provider, they'll take vital signs, you know, ask the patient, you know, why are you here? What's going on? And then based on that, they will then be roomed. So if a patient does have a medical concern that is occurring, in addition to a behavioral health concern, that will affect, in essence, like where they are bedded in our emergency department. I'm going to talk about this a little bit in a couple of slides, but we do have a designated locked unit in the emergency department specifically for individuals with behavioral health concerns. With those rooms, we do try and limit any potential ligature risks or things of that nature. So if we have a patient with medical concerns who maybe needs IV fluids, maybe they need to be hooked up to some continuous monitoring with vital signs, those individuals are going to have to be bedded in a what we would consider to be like a medical room outside of that locked unit. So that triage that is completed just helps to determine, does the patient need more of a medical workup, or could they maybe just go straight back to our behavioral health unit? After the patient is roomed, the primary nurse takes over that individual's care. So they may take vital signs again, kind of ask similar questions. What brings you in? What are you looking for? All patients who come in with a behavioral health chief complaint are required to change out of their clothes and into a gown or paper scrubs. So security is present with the nurse, and a patient safety search of their belongings is conducted just to make sure that there is nothing in those belongings that could be harmful to staff or to other individuals in the emergency department. The patient also is not allowed to keep their belongings with them. So the belongings are put into a bag, or if they have a bag with them, just put into those bags and then locked in a belongings locker that is correlated to what room they are in the emergency department. The patients are allowed to keep their cell phones, not their charging cords, just their cell phones, as long as they are using the phone appropriately. We've had individuals who have called maybe crisis or 911 saying we've kidnapped them or things of that nature. So if things like that happen, we will take the phone until they are able to demonstrate that they can be appropriate with the phone. Once that happens, the assigned medical provider will come and assess the patient. Again, just to determine, are there any medical concerns that need to be addressed, and to preliminarily discuss a potential plan of care. So if the patient's coming in voluntarily, maybe they want to sign themselves in for inpatient mental health treatment, that's something that the doctor is going to talk with them about very briefly, just to kind of figure out which pathway are we going to go down. Next slide. So then once that happens, the provider puts in a consult for my team, which is the behavioral health intervention team. It's a team comprised of both bachelor's and master's level clinicians. We come and assess the patient to help to determine what the best plan of care is for that individual. So if it's determined that the patient meets criteria for inpatient treatment, we will begin a bed search, insurance authorization if needed, anything to help support that patient being accepted into another facility. If the plan of care is for the patient to be discharged, we will try and provide appropriate referrals for that patient based on what they are presenting with. And that, of course, is dependent on the patient's willingness to accept those referrals as well. So even if the patient says, I don't want anything, I'm good to go, we will still put a general list of resources in their after visit summary, which they're provided when they're discharged. But if the patient is willing to engage in that kind of referral process, we will try and make actual referrals, set up appointments if possible for patients so that they can get that outpatient treatment. It is important to note that if a patient is going to go in for inpatient treatment, whether that be substance use or mental health treatment, there are medical tests that do have to be conducted just to ensure that there is not an organic cause that may be affecting the patient's symptoms. So every patient has to have a COVID swab, routine lab work, a urinalysis and tox screen, and then of course a pregnancy test for biological females of childbearing age. It's also important to note that if the patient is determined that they will be receiving, that they need to be transferred for inpatient treatment, they stay in the room in the emergency department until we have a bed for them and we can get them transferred to that other facility to start their treatment. So the emergency department is really more of like a holding area for patients to help them get to where they need to be. We're not doing counseling, we're not doing therapy, we're not doing really any type of intervention with the patient while they are here. That is the goal of getting them to that next level of care. Additionally, we do have psychiatry that works with our patients in the emergency department. So they will typically round at minimum once a day with patients. It could be more frequently depending on what the patient is asking for, or maybe behaviors that they're engaging in. Typically, they will not be starting new medications, but they will, in essence, like start home medications. So we have med history specialists who come in to do med recs. We will start home medications, including psychiatric medications, but usually psychiatry is not going to be changing those psychiatric medications because they're not able to continue to follow the patient to see, are they having side effects? Is it being effective? We want that patient to have that type of care through the appropriate provider, which is going to be a primary care provider or an outpatient psychiatrist. And then while the patient is in the emergency department, they are allowed to have visitors, as long, again, as the visitors are being appropriate and that the patient is being appropriate with the visitor as well. So typically it's just 1 or 2 visitors at a time. The rooms are not super ginormous. And then the visitors also are not allowed to have their belongings with them. So if you come in to visit and you bring in a giant purse, that purse will have to be locked up because, again, like, we don't necessarily know what could be inside of that. And we, again, want to keep the patient safe as well as our staff safe. Next slide. So then for patients who are looking for inpatient treatment, if the bed search remains exhausted for an extended period of time, so typically we're looking at like 48 to 72 hours, psychiatry and then my team, the BIT team, we will continue every day to reevaluate the patient to see, do they still meet criteria for inpatient treatment? So for a lot of patients that come into the emergency department, the ED is a very sterile environment. You're removed from your stressors, your triggers, the crap at home that you're having a hard time dealing with. And usually over time, patients do stabilize to a point where they don't meet criteria for inpatient care anymore. And so at that point, we will continue to reevaluate. And if that is the case, then we'll move to discharge and try and set up the appropriate resources for the patient at that time. And then if we do have someone that presents via EMS or police, the same process occurs. It just typically occurs more simultaneously, and the patient is just brought back to a room pretty much immediately, as long as there are no medical concerns. So if we have a patient who's brought in for an intentional overdose, maybe they took their entire bottle of Wellbutrin, obviously there's going to be a very in-depth medical clearance, medical testing that'll need to happen before we would be able to address the behavioral health concerns. Next slide. So in April of last year, so the entire ED has been subjected to about 5 years worth of renovations. And so the end is this month, actually. The construction will finally be done. But the ED in general, it's just gotten a really great facelift. It's just a much better space overall, whether you're in a medical bed or a behavioral health bed. So we did open up, it's what we call the PATH unit within the emergency department. This, in essence, took the place of what we used to refer to as the BHE, which was very institutional. So this is a 10-bed locked unit. We do have 8 flex rooms as well that are basically adjacent to the PATH unit that we can use specifically for behavioral health patients. We can flex them if that census is high. All of the rooms contain anti-ligature supplies, just again to help ensure the safety of the patients. And so the one nice thing too about the PATH unit is on 2 sides of the unit, the rooms actually have windows, so we get sunlight that comes in. Unfortunately, one side, they don't have any windows, but that's just because they're on the inside of the building. Next slide. So Rebecca talked a lot about commitment, so I'm not going to repeat anything, but just a couple of pieces to keep in mind. So any type of commitment, whether it's a 201 or a 302, these are legal documents. So if we have a patient who presents to the emergency department and they are drunk, so maybe their BAC is 400 and they say that they want inpatient treatment, they cannot sign themselves in for treatment until they are clinically sober, because again, it is a legal document. We also have to make sure, so they have to be medically cleared, and they have to meet necessary criteria, whether that be a 201 or a 302. So one piece that Rebecca had talked about was the 72 hours, and people get that confused. So that relates more to a 201. So, and Leo will probably address this a little bit more, but if we would have someone who is signed a 201 voluntary commitment, and they go to LBHH for treatment, for example, or whatever facility, and then they change their mind and they say, I don't want to be here anymore, I want to leave. Technically, that document, they are required to give 72 hours of notice if they want to leave prior to treatment being completed. On our end, because we are not necessarily a mental health facility that is treating their condition, if we have a patient who signs a 201 and then, I want to leave, I want to go home, I don't like it here, they do have to be assessed by a doctor before they are able to leave, just to ensure that they are safe to do so. And then if they are not, the doctor would then be able to petition a 302 for that patient. And again, Rebecca had talked about this, but the patient must present serious and imminent risk of harm to themselves or to others to be considered. So if someone comes in and they just want to sign themselves in because they feel like their medication needs to be reworked, but they're not suicidal, they're not homicidal, like that patient is not going to be approved to sign themselves in because they don't meet criteria. Special considerations are adolescents. So anyone from age 0 to 13, their legal guardian has to consent to any mental health treatment on their behalf. Individuals of any age can consent to their own substance use treatment. If we have someone aged 14 to 17, they can sign themselves into treatment without their parents' consent. So we've had that happen before. Maybe someone who is 16, they need mental health treatment, they want it, they're signing themselves in, but maybe their parents, for whatever reason, think, nah, depression isn't a real thing, and they don't agree with it. That adolescent can still seek that treatment. If we have an adolescent from age 14 to 17 who does not want treatment, but their parents or legal guardians do, the legal guardian can sign the 201 on their behalf. This is called an Act 65. So it's kind of in between a voluntary commitment and a 302. So there are facilities that will not accept an Act 65 commitment, who will take a 201 or a 302. There's just more legal ramifications with that. Next slide. So then a 302 or an involuntary commitment. So one piece that I think is just especially important to realize is that through the process that happens through crisis, for example, a mental health delegate has approved the 302 petition. Just because the petition is approved, that does not mean that the patient is going to receive involuntary mental health care. They still have to be assessed, and an examination has to occur by a physician. So that has to be either an MD or a DO. It can't be a PA or a CRNP. The examination has to occur by a physician to ensure that the patient requires emergency mental health care, because, you know, in essence, without it, they will die. So just because the petition is approved and they're brought into the emergency department, that doesn't mean they're going to, that 302 will be upheld and that they will receive treatment. So as Rebecca had said as well, the condition has to be a result of their mental illness and not a direct result of drugs or alcohol, intoxication or use. So if someone is drunk and they say they're going to go jump off the Eiffel Tower, that isn't necessarily a reason why we could 302 someone. We would have to wait until they are clinically sober and then assess them once they are sober. No one of any age can be forced into inpatient substance use treatment programs. So that is important to note. We've had that happen. You know, parents will call, or, you know, my son Joey, he really needs, you know, treatment for his alcohol use disorder. Joey has to consent to that. Additionally, things like psychosis, paranoia, and delusions. Those things specifically are not necessarily sufficient grounds for a 302. So the patient has to show that they cannot adequately care for themselves to the point that in the next 30 days, there's a good chance that they will die. So it is, it can be difficult because we may know that a patient could really benefit from care. But if we have someone, it's kind of what we consider like someone who's like pleasantly psychotic. They kind of live in their own land, but they function well enough to the point that they're not going to die. That's their right to kind of live that life. And we can't force them to have treatment. Next slide. And so when we have patients who either are on a 201 or an upheld 302, one of the first places that we will reach out to, as long as they don't have any off the bat exclusionary criteria, is LBHH. Because we want to try and keep people as local as possible. Their supports are typically here, and it just typically leads to better outcomes for the patient. So I will turn it over to LBHH.
Thank you, Ketra. As was mentioned earlier, my name is Leah, and I'm also joined today by our social work leadership team. So I have Karen Bramley also, who is our director of social work or social services, and Hannah Kissel, who is the assistant director of social services. Because I deal with the front end of care and they deal with the during care and after care process, I've invited them and they've graciously agreed to participate today to share some of their information as well, because they are the experts in that area. So thank you for welcoming them, and you can go to the next slide. All right, so that's a little picture of our hospital for those of who have not ever visited. We love visitors. If ever you'd like to arrange something, you can get in touch with our marketing team and come by for a tour. We're located on the corner of Charlotte Street and Harrisburg Avenue, right directly behind Clipper Stadium in Lancaster. So we get referrals or we get different individuals into care through a variety of different ways. So the most common way, as Ketra mentioned, is that we take referrals from emergency departments and sometimes acute care medical floors. So if there is a hospital that has somebody who has overdosed and they might be on the med floor, or there's somebody who is suicidal with a plan and access to whatever that plan might be, we will receive a referral once the hospital does a thorough evaluation of them, making that recommendation. And so what happens is they'll send that information to us in a packet. LG is great because we can just look up the MRN and see all the information once they share that with us. So the admissions team in my department, we have, similar to Ketra, both master's and bachelor's level clinicians, and they are reviewing referrals for medical and psych criteria. As Ketra mentioned earlier, the medical necessity criteria for inpatient, there has to be a level of risk that would make them unsafe in the community if they go untreated. Because we are a freestanding hospital, we also have to make sure that medically we're able to care for them. We do have nurses and doctors. However, if somebody requires more intensive monitoring for a physical health condition, we have to be very cautious about the medical comorbidities that come into our building, because we just can't accommodate every single medical concern. So for example, somebody who might need dialysis 3 days a week, they're going to be out of the building more than they are in. And for those of you who have ever experienced anybody on dialysis, those days in between or even out after they're very tired. They're not really going to be able to participate in treatment. So a medical-based facility would probably be more appropriate for them versus a freestanding. So we do get referrals and coordinate with hospitals that send those referrals and schedule for their transfer to come over. We also are happy to take scheduled assessments. So if there's a community professional who has an individual, whether it's a therapist or LGH has primary care offices that have embedded counselors there, they may call, fax, shoot us an email and say, we have this individual who would benefit from an assessment to see if they would meet criteria for inpatient. We do also now have an partial hospitalization program for adults. So if that criteria is not quite there for inpatient, we are able to occasionally offer that level of care as well. And so we will receive the handoff, what the chief complaint might be from the individual. And we always try to speak with that person before we schedule them for an appointment. The reason being is that sometimes the individuals are agreeing to come for an assessment and might not really know what they're signing up to do. So if they come and they want to, it's determined that they need to sign in. However, they might need to wrap up other personal items at home, or don't realize that, you know, being inpatient is quite a commitment. You're typically there for 7 to 10 days. Then sometimes they end up not wanting to receive the care. So we do like to have a warm handoff from the community professional, while also taking some time to speak with the individual before they come to make sure that it's a good fit for both sides. Because once we determine that they are not safe to leave and meet criteria for inpatient, we don't allow them to leave the building, to go home, to get clothes. So we do try to arrange that up front when we are able to have them scheduled. Our least favorite way to receive people are unscheduled assessments, but we are happy to do the assessments. And I say it's our least favorite way because there are unfortunate times when we might not have bed availability, or the person might have to go to LGH to be cleared anyway if they've ingested something or are under the influence of a drug or alcohol that clinically it would not be appropriate to assess them and might place them at risk. So these people are riding to our facility sometimes with a loved one. Sometimes they're duped into coming and not really knowing what they're showing up for. And sometimes they really are understanding what they're walking into and really need that assessment. But we do prefer to have that call ahead just to make sure that the entire environment is ready to receive that person so that they can be assessed and come into care. There are times when at any type of hospital, if you go to an ER and you have to wait, if the ER is very busy and you kind of get tired of waiting, you know, something similar could happen when we are not prepared for somebody to just show up if we already have individuals lined up for assessments throughout the day. And so we really try to limit that by being able to coordinate with the community if they are sending somebody our way who is in need of an assessment. You can go to the next slide. So this is our lobby. I think my words got a little shifted here on here, but that's okay. I'll try to read my blue font here. So once people come and present, we have some very friendly faces at the front desk who will receive that individual if they are a walk-in. And so they will go over some paperwork and retrieve their belongings. So we're similar to LGH, as when the person is identified as being in need of a behavioral health assessment, we want to make sure that there are no items that could pose a threat to themselves or the staff in the building. So we secure that behind the front desk. We don't have a fancy metal detector, but we do have a wand. So they're wanded, they get some initial vitals, and then they're able to enter. If you see that door to the far right, there's a subacute area. So our subacute area is a more private area, so that you're not out in the rest of the lobby with the general public who might be coming in for visitation or discharging somebody, or a family member coming to pick somebody up who is leaving. And so we have that area for them to be able to complete their paperwork. If it's at a meal time, we're happy to go grab them something to eat from the cafeteria. They have a TV. So it's a nice little comfortable place that provides a little bit more privacy. When they come in, the master's level clinician or RN will complete an assessment to gather information. So this is not an evaluation. There are times we get calls from probation, for example, that they want somebody to have a court order eval. That's not what we do at all. We are simply assessing for risk to determine the best level of care for that individual, in our opinion. So things that we'll gather are the chief complaint. So what brought them there today? What is their behavioral health concern? We look at the symptoms and treatment, past and current presentation. So have they had treatment before? Is this a new onset psychosis? Have you had any history of suicide attempts, just to help formulate the level of risk that person might have? With that, we'll also complete the Columbia Suicide Risk Assessment and determine if they are rating at a low, moderate, or high level of risk for suicidality. And then we look at risk and protective factors, which is very helpful for our treatment team once they are signed into care for them to develop their treatment plan. You can go to the next slide. So to our left is our consult room. So you'll see nice green walls and kind of serene picture there. So that's our typical consult room. In the admissions department, we have 5 of them. We do share some of them with partial. We also share some if like social work has meetings or there's a special family event happening and they want to arrange for a more personalized individual experience for somebody who's in treatment, they are welcome to come use our consult room. But this is the room where we will complete our level of care assessment with the individual, whether they're a walk-in or the initial assessment if they are a transfer. So in general, if somebody's on a voluntary commitment, we do assess them up in the intake area. However, if they are on an involuntary commitment, we generally take them right to the unit to assess them in the event that there's an emergency situation and they need to be given some emergency medication or any type of therapeutic intervention to help keep them safe. So we manage it that way. We have an SBAR that helps us communicate to the unit what is going on with that individual after we do the assessment or after we receive a referral. So it's just basic information. We gather it generally from ER documentation. So what's their risk? Are they suicidal? Are they homicidal? Is there a history of assault or violence that we need to be mindful of? Are there any concerns potentially with sexual acting out or being victimized sexually? We look at their medical presentation to make sure that we're able to care for all of their needs. So we do have availability to be able to take somebody with a CPAP, for example, but we just want to make sure that we are covering all of our main bases before we accept somebody into care. So this information then, once we accept the individual, goes to our nursing unit that's going to be taking care of that person. And then so you'll see the picture on the right is one of our nursing units. And you'll see that it's not as sterile. So I know Ketra mentioned earlier that the ER is a different type of setup, but this is more therapeutic because this is when they are going to start their journey to wellness. So we have a nice open nurses station. Sometimes that becomes a challenging part of the job because if a person is dysregulated, they like to somehow test how high they can jump and cross over it and make the scene a little bit unsafe on occasion. However, in general, it's very well managed. Our nursing team really does a good job of trying to stay out in the milieu anyway and to interact, or if there's groups going on with social work, they're able to just be present and interactive with the individuals who are receiving care. You can go to the next slide. And now I'm going to hand it over to once they are into care with Karen and Hannah.
So once an individual is admitted to one of our suites, so just to back up, so everybody that is admitted is seen by a social service therapist as soon as we can see them. So hopefully within 24 hours, but we do have up to 72 hours to do our assessment. But again, we really try hard to meet individuals as soon as we can. The sooner that we can meet an individual and start understanding what's happening with them and really building off the information that has been gotten in the emergency room and through intake. And then we can, with permission, reach out to supports and community professionals. The more able then we're able to get a clearer understanding of what's happening with the individual and some of the goals that we could work on here. And then, treatment can get started in a more accurate way. So we do a biopsychosocial evaluation, which includes assessment of the social determinants of health, as well as building on, again, like information that's already gotten through intake, through the emergency room, past and current treatment, what's happening with the individual, who are their supports, who are the professionals involved, housing. So really, right from the beginning, as best we can, we're really trying to look at what is their situation and then starting to think about what is the discharge plan going to look like, because we have so many challenges in the community and for individuals with housing, with accessing services, with all kinds of challenges. We just try to start right in the beginning. Sometimes though, individuals really are not able to tell us. And this is where we run into more of a challenge when individuals are, not in touch with reality, or they're confused, or, they just can't recall for various reasons. They're psychotic, or, just with the level of acute symptoms that they have. So, we do our best to really understand the individuals that are involved with them. But this is why, like when Ketcher or Leah talks about, like, if you can make a phone call to us, leaving us a voicemail, reach out to intake if you think that your person is admitted or here, even just to say, hey, I'm working with that person. It is so helpful because we don't always know and the person can't always tell us. And even though they might have been seeing and involved with you for a very long time, or that professional, sometimes they just can't recall the name. So again, just any like that open dialogue as much as we can. We have a lot of stipulations, which I'll try to talk briefly about because I know we have limited time. But with our confidentiality policies, again, that's a legal HIPAA issue. But we can take information. So if people can leave us a message, it really helps us. So we determine treatment goals based on the assessment of the social service therapists, which are master's level professionals, as well as our psychiatrists and our nursing department. And that treatment plan and what the individual needs then lends itself to the length of stay here, which, then the individual is evaluated daily to see how they're doing on their treatment goals, how their symptoms are resolving. And again, that helps us to determine how long someone will be here. And someone can be here 2 or 3 days, someone can be here 9, 10 days. And then we have a whole section of individuals that are here longer, and again, that is determined just by their situation and by what their needs are. Once their symptoms start to resolve, then again, we're continuing throughout their stay to talk about their discharge plan. And as their symptoms are resolving, then we are trying to firm up their discharge plan. While they're here, they have group therapy, and each suite has its own schedule. So they have different activities and groups throughout the day. We have an expressive arts department, so they're receiving like music therapy, art therapy, rec therapy. And, we have our psychiatrists here on site and close, communication with them. So looking at, medication issues. And again, with the idea, like, how is that person going to get their medications upon discharge? And, we have some, ability to be able to assist with that initially when someone's discharged. Can we go to the next slide? So again, just talking about aftercare planning, like I was saying, right from the beginning or as soon as we can throughout their stay. We are reaching out to supports. As soon as we do the assessment, we're reaching out to supports with permission. Sometimes people decline to give us permission. We continue throughout their stay to encourage them. And sometimes we'll say, hey, if you're really wanting to be discharged, we really need to talk with someone. And so, and sometimes they will permit that if they're in the room, or, sometimes we can have a meeting together. So we do continue to try to encourage that involvement. And again, also with professional supports. We're looking at housing throughout their stay and saying, if you are homeless, do you have any options? Do you have someone that you can stay with? Do you have a friend? Can we send you out of state? Can we look at another county? If we're looking at a shelter, then we're trying to figure that out as well. upon discharge, we're connecting people to therapy, psychiatry, primary care. Sometimes we're looking at a partial hospital program. We're looking at dual services because not only do we connect people to mental health services, we're assessing for, that dual issue, the drug and alcohol issues. If someone has insurance, maybe we're sending them to rehab or dual treatment. So really do try to take inventory of what are the primary issues and, where can we send people for services, because not only it's important what happens here, but it's really important to try to connect people to services. And sometimes people want to decline that, and we continue throughout their stay to encourage that, even just one place that they'll follow up with. That would also include peer support, case management, anything that they're agreed to. Next slide. So we do a crisis safety plan throughout the individual stay, and we firm that up, prior to discharge. And you can see we're looking at triggers, we're looking at warning signs, goals for healthy behavior, people to contact. We do our best to secure safety, like, wherever the person's going, do they have access to guns? Can we minimize their access to medications or, just dangerous situations, and just try to foresee, like, if you're going to be walking back into a situation that's difficult, how can we help you to cope with that? And really look at coping skills. And a lot of our groups are geared towards coping strategies. We review the safety plan with the individual, with their supports. And then can you go to the next slide? So on the back of the crisis plan, we have a lot of resources. And we also have these resources on our after visit summary that the individual gets when they're discharged. And you can see it's a variety of resources and websites and, just trying to put as much as we can in terms of resources, because again, we're also looking at the social determinants of health. And sometimes people are here a very short time. So as much as we can give them in resources, written information, we will do so and connect people to services if they're willing, and, hoping that they're going to follow up with that. Can you go to the next slide? We have a specialized program here that we're hoping to implement throughout the hospital. It's called the Re-engineered Discharge Planning Program. It's REDIS for short. It is evidence-based, and it takes into consideration various components of a successful discharge. And we utilize this program for our high-risk individuals. And it includes a follow-up series of phone calls to ensure that the individual is still doing well, or to be able to troubleshoot and problem solve any issues. And it's been very successful in other medical settings as well as inpatient settings. There's several other hospitals in the area that are utilizing this program. And it really, again, targets our high-risk individuals that with, again, success for, offsetting readmissions, high utilizing of the emergency departments. Next slide. So discharge criteria. So I'm just wanting to talk again, really focusing on treatment goals here, focus on safety, decreasing symptoms that impact the individual's functioning. Just wanting to talk about imminent danger, that if individuals are no longer feeling suicidal, or if they came in and they were homicidal and those are resolving and they're caring well for themselves, and again, meeting their treatment goals, but again, challenges with discharge planning and housing, we cannot keep people here indefinitely to solve that issue. So we are under pressure with the individual to really problem solve that challenge. And we do our very best, as I said, right from the beginning of the individual stay, to assess people's resources and options, And so at times we are having to resort to utilizing shelters. And if there are no shelters involved, or the person's preference is to, be discharged to a situation in which they're utilizing day programs or, just intermittent community resources, then sometimes we need to do that. And this is where we feel pretty challenged, and we would really love to collaborate with more so with the community. And what do we do when we are out of options and we have nothing to provide to someone in terms of housing? Like all the shelters are full and the person is really doing well, and they don't meet criteria to stay. And we've tried everything that we can think of. So this is, again, our challenge. People can sign 72-hour notices, what you've heard people talk about throughout the presentation. And again, that puts us in a situation where the person wants to leave. They've given us notice that they're leaving. They don't have resources. And then we're forced to let them go because we don't have any reason to hold them to stay. And we try throughout this day to encourage people to stay as long as they need to. But there again are times that our hands are tied in this way, and the person makes certain choices in which we can't impact. Let me see, am I missing anything? Again, if the person has housing, if they have a situation they can return to, we're happy to put any kind of resources in place that we can think of. But again, we've been challenged sometimes with, again, housing resources, but also therapy resources in a timely way. So just a quick discussion about our releases of information. So
Can you change the slide?
yeah.
Thank you.
So on admission, as Leah was discussing, we do meet with the individual. We encourage them to allow us to communicate with any supports, any community professionals that they would allow us to. Sometimes people decline. And again, we keep encouraging that. Sometimes people say, I don't have any resources. We, again, just continue to think about like, who can we connect someone to? So we have utilized the LGH street doctors who have come in and met with individuals here, like if they're going to be homeless and we really don't have any place to have someone, go, or if they prefer to just be sleeping where they go and sleep in the parks or wherever. We do utilize the street doctors. We are able to have them leave with a supply of medication. We have an agreement with Altruix that we will pay for medications. Do you want to go to the next slide? We also will do occasional overrides for communication. We're able to do this legally. If the physician feels that the individual just doesn't have capacity in that way to make that decision in that moment, we can override their decision to decline to sign a consent for somebody that would allow us for a one-time discussion with family, supports, a community professional, just to be able to either gain information or to be able to give information related to their situation. Just looking at, as I was starting to say about collaboration, like barriers, individuals not always aware of the members of their outpatient team. Sometimes they decline to sign releases of information. They're too ill to consent or recall details. And, we would love to, like, we know about the street doctors that we can access in this county. And I think there's another county, I think it's Dauphin, that we've been able to do that. But is there other people that we could be reaching out to that we're not aware of, that, you could have these individuals on your radar in case they would need something? Or we could say, hey, could you go to this place or talk to this person if you feel like you want to do something different with your situation or you're trying to seek housing other than like the food hub where we sent people. We also, I put Hannah and I's phone number here as well as an email. Many people do this. They leave emails for us. They leave messages for us. Hey, is my person there? Or I think, my person's been admitted. If so, this is the person that, you can contact. So, or this is information I want to leave for you. I know that maybe you can't call us, but I want you to know this. And that has been extremely helpful for us. And again, many times when you don't hear from us, it's because our hands are tied. It's not because we don't want to collaborate. And I will stop there.
Wait, Beth, go to the next slide. That would be great. Hey, thank you so much to everyone who has presented and shared this wealth of information. If you can take a look at the chat, you can see a lot of kudos are coming in. We are over time, and so we will not have an opportunity for a Q&A today, but we do have the QR code up here for training evaluation. Like for you to just get your phones out and to fill out that quick evaluation. It gives our presenters feedback, and it also has some questions as it relates to upcoming trainings. Beth will send out the PowerPoint and also an evaluation link for all the people who have signed up. I know a lot of people had to drop off because of other commitments, but I just want to say to Rebecca, Ketra, Leah, Karen, and Hannah, thank you so much for being here. This is so important for our community, and we really appreciate all that you've done to prepare for this and to train our teams here across the county. All right.
Thanks for having us.
I dropped my email address in the chat, so if anyone would have any questions from the LGH or emergency department side, just please feel free to shoot me an email and I'd be happy to connect.
Wonderful. Thank you all for your time here today, and expect an email from Beth. And again, thanks so much to the presenters. We really appreciate it.
Thank you.
All right, enjoy your day.